My name is Andrea Trescot, and I'm going to talk today about pain generators and are they really independent? I am a past professor at the University of Washington, past director of the pain fellowship programs at the University of Florida and the University of Washington, past president of the American Society of Interventional Pain Physicians, and past president of the Florida and Alaska Societies of Interventional Pain Physicians, as well as the chief medical officer of StimWave Technologies, though that has nothing to do with today's lecture. So when we look at acute pain and its pathways, it's very straightforward. But when we start looking at chronic pain pathways, they get very much more complicated. And so currently we're doing a very poor job of treating low back pain. And if you just look at the number of fusions that are being done, you can see this dramatic increase over the last 20 years. And you end up with the patients showing up in your office like this. So we're going to talk about some of the sources of low back pain and see if we can figure out a way of perhaps treating these patients better. So we know that discs cause pain by direct compression of the nerve root. And in fact, in 1934, Mixter and Barr identified a herniated disc as a cause of pain going down the leg. And because we already had the Greek word for pain going down the leg, sciatica, the term sciatica and disc ended up becoming synonymous. But we also know that disc can cause pain by chemical irritations of both the nerve root and the annular nerves as it comes out. So if it actually comes out onto the nerve root, it creates a terrible inflammatory response. So McCarran looked at the disc material from the tail of dogs and compared that to normal saline when he injected it into the epidural space. And you saw this huge inflammatory reaction, which we can actually see under spinal endoscopy. This is what's felt to be the mechanism of pain from annular tears, is pain into the annular nerves or leaking out onto the disc, creating inflammation there. And we see that on MRIs as a high intensity zone. The vertebral body itself can cause pain. The end plates and the vertebral bodies are innervated by the basovestibular nerve. And when those end plates get irritated, those nerve fibers carry the pain signal into the spinal column and the sympathetic nerves. So we are able to identify a variety of changes that are going on at the end plate. It's the type 1, where you have a low signal intensity on T1 and a high signal intensity on T2. It represents a fibrovascular tissue, inflammatory changes, and perhaps edema. And there is a correlation between back pain and modic changes, especially with this modic change type 1. The nerve roots can be compressed, they can be inflamed, or they can actually be adherent with adhesions that occur because of inflammation that occurred in the past. And we can see these adhesions again on spinal endoscopy, or when you're doing a epidurogram, looking at the way the medicine spreads. You can have facet pathology. The facets and facet arthropathy are a common cause of low back pain, and the medial branch of the dorsal ramus innervates the facet joints. We also have the sacroiliac joint, which is another cause of pain going down the leg, or what I like to call pseudo-sciatica. The joint is innervated by L5, as well as S1, S2, S3, S4, and S5, but it's primarily S1 and S2. And unfortunately, it's not well visualized by standard lumbar MRIs, both because they pretty much stopped taking the axial views at the L5 disc because the radiologist is looking for discs, and because the joint itself really can't be viewed in any single plane because of its shape. It's shaped almost like a boat propeller, twisted and curved. And then we have a wide variety of ligaments. The spine and the pelvis are held together by these ligaments, which include the iliolumbar, the long sacral, the sacrotuberous, the sacrospinatus, the supraspinatus, the interspinatus, the anterior longitudinal ligament, and the posterior longitudinal ligament. And you can see those here, where you have the interspinous and supraspinous ligaments holding the spinous processes together, the iliolumbar ligament coming onto the iliac crest, the sacrotuberous ligament running from the sacrum onto the ischial tuberosity, and then anteriorly we'd see the anterior and posterior longitudinal ligaments. And these ligaments seem to cause pain because of an enthesopathy. It's actually a disease pathology at the enthus, or it's the attachment site of muscles, tendons, joint capsules, ligaments, and fascia to the bone. And because the bone is innervated, you will get a periostitis and an inflammation at that attachment. The body's response to that is to lay down calcium. And so you'll see this as bone spurs, and under ultrasound, you'll see it as a neovascularization as the body tries to repair itself. We've got a wide variety of muscles. We've got the paravertebral muscles. Then they can cause a variety of pain patterns, including the gluteal muscles and the piriformis muscles and the quadratus lumborum, just as a few examples. And then we have peripheral nerves that can be causing pain. So we can see a wide variety of nerves that are in just the pelvic region that might be entrapped and causing pain. So we've got some diagnostic studies. We have myelograms. We have CTs, MRIs, EMGs, and nerve conduction studies. But unfortunately, MRIs don't show pain. This study is absolutely landmark in my mind, and anyone who's treating low back pain really needs to have read this article. So you had 98 asymptomatic patients, but you had this huge number of them that had disc protrusions and disc bulges and disc extrusions, as well as these things we've been talking about: annular defects, facets, spondylolisthesis, stenosis. All of these were in patients who did not have any pain. And in fact, when these films were shown to surgeons, 40% of the MRIs were offered surgery in asymptomatic patients. And it's been repeated time and time again. When you look at, in this particular study, they looked at people in their 80s, and virtually 100% of them had disc degeneration. But they also had disc bulges, disc protrusions, facet degeneration, and spondylolisthesis. So even in the 60s, disc bulges, and if you look down at the 20-year-olds, more than a quarter of them had disc bulges and disc degeneration. So these are patients who are otherwise healthy and pain-free. And so you can see things like this. You see this amazing spondylolisthesis. This patient was pain-free. You see abnormalities in the structure of the spine. So you'll see a pseudarthrosis and a sacralization on one side. Now, I can guarantee you this patient had no pain because this is my x-ray, and I have no back pain and never have had any. So you have to look at the physical exam and the history. The words the patient uses, I feel, are very important. The pain started in my upper back and then went to my hip and then my leg. The pain switches from side to side. My knee gives way and I fall without warning. I was bending over, lifting a box, and I felt my back pop. All of these actually are very characteristic of problems that are not from herniated discs. So you then need to do your physical exam with inspection and looking for abnormalities. And one of the things that I found particularly useful is something that Dr. Gabor Rax identified, which was a Dural Tug. And the concept is you have the patient sit, slump forward, and then bend their head forward, and they'll feel a pain, and they can actually usually point to it with one finger of where they're hurting. And this seems to represent an area where the nerve roots are adhesed. And so when you bend forward, you're putting a tug on the dura where it has stuck down into the epidural space. So if we're going to do this physical exam, let's start with your hands at the top of the iliac crest. And this gives you can examine most of the back starting at this area. So that'll be the L4-5 interspace at the top of the iliac crest. And you can, at this point, feel up and down. You can feel in the interspinous ligament. You can feel over the paravertebral muscles, and you can feel into the facets themselves. If the muscle, especially if you have the patient leaning over, holding on to the bed, because that will then put the muscles under a little bit of tension, and you can feel them and then move them a little bit out of the way. You can feel, as I said, the interspinous ligament that interspinous ligament can cause pain going down one or both legs. These are drawings from medical students. This happened to be done in 1954 with Feinstein, and of course you could do anything with medical students in those days. They injected 1 cc of hypertonic saline into the interspinous ligament at multiple levels and had the poor medical students actually map out where they were hurting, and that's what you see here. And it would be on one side or the other or both. And then you move a little bit more laterally to the iliolumbar ligament. And this iliolumbar ligament runs from the spinous process onto the medial aspect of the iliac crest, the most medial aspect. And as I said, the body can put down extra calcium in that area that you can sometimes see on x-ray. And the pattern of pain of this is very characteristic. It'll be across the top of the iliac crest and down into the groin, as well as a pseudotrochanteric bursitis. This pain will go in guys to the testicle and in women to the vulva. And though women don't usually complain about it, men will often use the term, my testicles are in a vice. And they'll get evaluated for hernias and they'll see the urologist to see if there's a problem with their testicles. If you go just a little bit more laterally, you'll find the superior cluneal nerve. And it passes through the quadratus lumborum and gets trapped at the top of the iliac crest and can cause pain going down the buttocks and down the back of the leg toward the foot. If you drop your fingers down, you'll get to the posterior superior iliac spine. And this is the location of the Fortin finger, the location where the patient will point with one finger. And Joe Fortin wrote an article on this as a joke, and it actually got published, and that's what it's now known as. But that PSIS tenderness has a very high relationship with sacroiliac pain, and the sacroiliac joint can cause pain going down the leg. And because the iliolumbar ligament will be put under tension if the joint is rotated, then you'll often get the symptoms of the iliolumbar ligament as well with groin pain. And the only muscle that holds that joint together is the piriformis muscle. So if the sacroiliac joint is irritated or unstable, then you'll get spasm of the piriformis muscle, and that will impinge on the sciatic nerve as it crosses over the pelvic brim. And so on MRI, you can see the sciatic nerve. And if you look carefully, you can actually see the piriformis muscle as well. Drop your fingers down on the edge of the lateral edge of the sacrum, just where it changes its angle from going vertically to moving toward the midline to join together to make the tip of the coccyx. There you'll see the sacrotuberous running from the sacrum onto the sacral tuberosity, as well as the sacrospinatus ligament. And this will cause pain going all the way down the back of the leg to the foot, and sometimes coming onto the top of the foot and the toes. And you'll see it there at the edge of the of the sacrum. The superior gluteal nerve is actually in the buttocks region. It lies between the piriformis and the gluteus medius muscles. So anytime you have the piriformis going into spasm, you run the potential for entrapping the superior gluteal nerve. And that will give you buttocks pain as well as pain going down the leg to the foot, another pseudo-sciatica. And then we have the muscles themselves. We've already talked about the piriformis muscle, but you also have the gluteus medius, the gluteus maximus, and the gluteus minimus. And each of those have their own patterns of pain. And you can see those. Here's the gluteus medius, the gluteus minimus, and the gluteus maximus. So are all these pain generators independent? That was the question I was given. We have to be able to identify the underlying problem to be able to fix or prevent it. So let's start with a young, healthy spine. Where do we start to go wrong? So one of the big ones is posture. And I think that's why low back pain is getting worse and worse and worse, because what do? Where we spend our entire day looking at that little box that sits in our hands and controls our lives, the cell phone. And when you're taking your head from a vertical position to leaning forward, it goes from an equivalent weight of about 10 to 12 pounds to as much as 60 pounds. And that clearly will then put stress on the low back area. And so sitting on a wallet or crossing the same leg all the time will end up with uneven shoulders, strained spine, and uneven hips. And when all this time we're spending sitting at the computer doing our notes, you'll see also tremendous stresses in the upper back, the neck, and of course the low back as well. And bending over to lift. We teach sex education in the 3rd grade, but we don't teach people how to lift things until they hurt themselves. This said, having shrewdly cemented a solid gold bar to the sidewalk in front of his office, Dr. Nertman immediately experienced a 70% increase in business. So that posterior ligament, as you lean forward, can be stretched either gradually or suddenly. So when somebody bends over and goes to lift something and feels a pop, that pop is not the disc. That pop is that posterior, the interspinous ligament, the supraspinatus and interspinous ligament. And what will happen then is you'll have an anterior pressure on the vertebral bodies, which you'll see by changes in the vertebral bodies anteriorly. And that leads to an anterior pressure on the disc. And if you have an anterior pressure on the disc, then you're going to get a posterior bulge. And if that if that disc has enough pressure on it, the bulge starts to push its way through the annular fibers and eventually ruptures. Now, all of you have seen an x-ray that said a loss of lumbar lordosis secondary to spasm, but I challenge you, if you've got a lordosis, that C shape, and the muscles attach at the top and the bottom of that C and they go into spasm, does that make the lordosis more or less? Well, it's got to make it more. So the problem is not that the muscles are causing the loss of lordosis. It's that the loss of lordosis is because of the spasms. So as you disrupt those posterior ligaments, now instead of the ligaments holding the spine together, the muscles have to. And that will then lead to pain going on up the back. The facets move more, and that creates the spondylosis that we see. And the intra-articular fluid and the potential for synovial cysts and nerve impingements from that. And because the discs are not stabilized, you're going to get an accelerated disc degeneration. And so you have, at this level, you've got a beautifully normal disc, nice soft center, fibrous outside covering. But we've got disruption of the posterior ligaments as we go down. And what you start to see is the disruption of the disc. It's starting to degenerate. And then you end up with the dreaded black disc, where there's been just a complete disruption of the disc material and the degeneration that occurs from that. And so you notice the ligamentous pathology, where the muscles are no longer attached to the bone. And those of you who paid a lot of attention, there's a little Tarloff cyst there as well. And this is causing now a bulge, a posterior bulge. And what do you notice there? A little bit of an HIZ. So is it the disc that's causing the pain, the facets that are causing the pain, the paravertebral muscles that are causing the pain, or the disruption of the interspinous ligament? Or is it all of the above? Well, we know that the innervation of the interspinous ligament, the facets, the disc, and the muscles all come into the spinal column at the same level. And that's why it's so very difficult to try and make a distinction for the individual types of causing a pain. And that's why, in my mind, the diagnostic injections, which are a whole nother lecture, are so absolutely critically important. Before you start doing radiofrequency of facets, before you start doing epidurals, before you start doing disc decompressions, I think it's absolutely critical to have a good diagnosis. And in my mind, that diagnosis is made up of a combination of history, physical exam, and diagnostic injections. And I think it was said best by Joseph Bell back in the late 1800s. He was felt to be the inspiration for Sherlock Holmes. And he said a diagnosis rests on three things: observe carefully, deduce shrewdly, and confirm with evidence. Thank you very much.